Good evening, guys. Myself, Dr. Mohan Babu. I welcome you all for the Part 2 Physiology MCQs. Before starting to the MCQs, I would like to sensitize you again to the Medicoz Community platform and the offers which is available in the platforms. It is a perfect e-learning platform available for the NEET preparations and the next exit examination preparation students. The early bird offer is live, and go to the website medicozcommunity.com website and hurry up, because this early bird offer is valid for 3000 members and get huge premium discount on the all available plans on the Medicoz community. The plan includes various live interactive sessions, test series, question banks and e-notes by the expert faculties. So don't wait, guys, go and book and enjoy learning with us. Okay, let's start the remaining 13 questions for the today. The question number 13, which of the point in the graph shows the values of partial pressure of oxygen and carbon dioxide in a patient diagnosed with pulmonary embolism? Okay, guys, is the option A right, or option B, or option C? Try to find the answers. Okay, before going to the answer, we should understand what is this diagram or the image tells us. It is the x-axis shows the partial pressure of oxygen and y-axis partial pressure of carbon dioxide in the alveolus, and this is the line indicates V by Q. So this graph is partial pressure of O2 and partial pressure of CO2 in alveoli and V by Q line diagram. Okay, imagine if a patient having a normal ventilation and perfusion. If the ventilation and perfusions are said to be normal, the ratios will be 1. Think, if the patient is having a V by Q ratio is equal to 1, what will be the values of PaO2 and PaCO2 in the alveolus? The PaO2 will be 100 millimeter of mercury and PaCO2 will be 40 millimeter of mercury. It means that the normal gas exchange will taking place across the alveolus and pulmonary capillaries, so that the PO2 in the alveoli will be 100 and the PaCO2 will be 40 millimeter of mercury. Try to plot these values in the graph. The x-axis, this is the PaO2 100 and y-axis PaCO2 40. If we line these 2 points, it will be coming in the point B. So the point B is the point where you have having the V by K ratio is equal to 1 and our PO2 value will be 100 and PCO2 value will be 40 millimeter of mercury. Imagine, for example, this V by Q ratio is not equal to 1 in all the parts of the lung, right? So V by Q ratio will be around 3.3 in your apex. It means that you know that the ventilation in the apical part of the lungs will be very high compared to the perfusion going to the apical regions. Perfusion is less and the ventilation will be very more, right? If I say ventilation is very more, it means that the more amount of fresh oxygen will be coming into the alveolus, and since the more number of fresh oxygen is coming into the alveolus, for the less amount of blood flowing in the apical regions, the PO2 generated in the apical part of the lung will be very high, or we can say it's the highest in the apex. If I say highest in the apex, the PO2, then what will happen to the CO2 value? The CO2 value will be very low, because the very small part of the CO2 reaching the alveolus, the apical part of the lung, because of the higher ventilation, the CO2 gets easily washed away. So there won't be any CO2 partial pressure developing in the alveolus. So the partial pressure developing in the alveolus of the CO2 will be very, very less. So can you find the point in this graph? Does it go below this point B for the apical region, or does it go above to the point for the apical regions? Guess by seeing the look upon the values of PO2 and PCO2. The PO2 value will be high only if you go down from the point B. So this is the point where you have V by Q ratio of 3.3. So we can come to a conclusion that if the V by Q ratio is equal to greater than 1, it means the graph will move downwards. If the V by Q ratio is less than 1, the curve move upwards, and both the values of PO2 will decrease and the values of PCO2 will equal to that of the PCO2 entering in the arterial end of the pulmonary capillaries. Okay. So that is around 40 and 45 millimeter of mercury of O2 and CO2 respectively. Okay. Imagine I said when you go down this graph, the V by Q ratio more than 1, and at a point it will reach the V by Q ratio is infinite. Is infinite. When I can say V by Q ratio can be infinite, only the denominator becomes 0, I can say V by Q ratio will infinite. So I don't want the pulmonary alveolus to get perfused. That is our question. In pulmonary embolism, there is no blood flow in the capillaries. So no gaseous exchange can take place, right? So in that condition, what will happen to the PO2 and PCO2 values? Okay. So from this the graph we can come to know that. So the PO2 value in the atmospheric air is around 160 millimeter of mercury and CO2 is 0.3 millimeter of mercury. When we inspire, due to the humidification, the PO2 will be decreased to 149 and PCO2 is approximately 0. Now tell me, in a pulmonary embolism conditions, there is no blood flow. What will happen to the PO2 value in the alveolus? It is nothing but same as that of our inspired air. So the PO2 value is around 149 and PCO2 value will be 0 in this point. Okay, and this type of ventilation, what do you call as dead space ventilation, because the amount of air reaching the alveoli does not take place in the gaseous exchange because of the block in the pulmonary capillaries. Okay, so the answer for the question is the point C. Okay. Moving on to the next question. Question number 14. A 20-year-old woman present to her primary care physician with recurring muscle cramps that have lasted for the last 2 weeks. She mentioned that constant tinkling sensation around her mouth. On physical examination, her vital signs are stable and the Trousseau sign and Chostek sign are present. The moment when you saw these two signs are present, you can come to the conclusion that the patient is suffering from hypocalcemia, right? In order to support these clinical findings, we have the laboratory values, which is also the calcium level will be low here, right? This is the easy catch points from the questions. And what is the question they are asking? Which of the following electrophysiological mechanisms best explains the human's clinical features? I can say from the clinical the history the woman has given, all the signs organ exaggerated activity of the electrical activity generating in the muscles or in the nerves. Okay. So because of this exaggerated activity only, our deep tendon reflex is exaggerated and our Trousseau sign and Chostek signs are present. Okay. So what is the relationship of this calcium and the excitability developing in the nerve and the muscles? This is what they are asking. See the option number A, stimulation of GABA receptors You know that GABA is kind of an inhibitory receptor, right? So there is no chance of this excitatory actions produced whenever the stimulation of GABA takes place. Now think of the second option, decreased firing threshold for an action potential. Is it possible? Yes. This is the answer for this MCQ. Decreased firing threshold for the action potentials. How? Imagine this is a cell and this is the sodium channel at a resting state. This is the cell at a resting state and this is the sodium channel, and whenever we have a calcium in a normal range, this calcium go and try to stabilize this sodium channel. What? It stabilize these sodium channels, and resting membrane of this cell, for example, it is found to be minus 90 millivolt. Okay, think. Now coming to the clinical question given here. Again, this is the cell and this is the sodium channel, but now the calcium level is low here, right? There is no enough calcium in order to stabilize this sodium channel. Since the stability is lost, the sodium channel can enter inside the cell at a resting stage also. Now, if the positive ions gets inside the cell, what will happen to the RMP? Now, the RMP will shifted towards the positive side, or it moved towards the positive side. Now, it becomes minus 70 millivolt. Now, tell me, to excite a cell of resting membrane potential minus 70 millivolt is easy, or to excite a cell of minus 90 millivolt is easy? Definitely. To excite a cell of minus 70 millivolt is very easy. It means the stimulus or the threshold to stimulate this nerve, the muscle has decreased. So this is what the decreased firing threshold for the action potential. Okay, so think of hypocalcemia, the resting membrane potential will shift towards depolarized side, or the membrane getting more depolarized. So it is very easy to excite this cell, whether it can be nerve or the muscles. Okay, that is what the reasons behind the clinical signs of the hypocalcemic patients. Okay, shall we move to the next question? Okay, compared to the normal ventricular pressure volume loop, that is the gray thing is the normal one. The red loop indicated by the arrow represents the independent effects of option A, increased afterload, option B, increased inotropy, and option C, increased preload, option D, decreased preload. Guess, try to give some answers. Okay, what is this graph? What is this image? This image is nothing but left ventricular volume, the relationship showing the left ventricular volume and pressure during an cardiac cycles. Okay, first the ventricle will start to fill from here. What is happening here? The volumes keep on changing, but the pressure does not increase that much, because since the ventricle is relaxing, the blood fill is taking place inside the ventricles. Okay, because of the compliance of the ventricle, the pressure is not increasing that much, only the volume is increasing, right? Can you able to see here? Volume is increasing. This is the rapid filling phase and slow filling phase, and it is a final filling phase of the ventricle, which is nothing but our atrial systole. Okay, then after that, what will happen once the ventricle gets filled? Now here, what is this valve? This mitral valve gets closed. Okay, and here our systolic phase begins, which is nothing but the first is isovolumetric contraction. Here the volume remains same and the ventricle is contracting against two closed valves. Okay, and once this pressure generating inside the ventricle overcomes the afterloadic pressure. What is afterload pressure? This is the pressure found in our aorta, which is nothing but the minimum pressure, that is of 80 millimeter of mercury, that is the pressure found in the aorta, which act as the afterload for the heart in order to pump in the systole phase. Okay, once the pressure generated in the ventricle, it crosses the pressure in the aorta, the semilunar valve gets open here and the rapid ejection phase begins and followed by slow ejection phase, and once the pressure in the aorta decreases than the ventricle, the valve again gets closed, semilunar valve closed again, and again the filling phase begins with isovolumetric relaxation. Okay, so this is the complete pressure volume loop, and this is a place where you hear the first heart sound, and this is a place where you hear the second heart sound. Okay, and over here the rapid filling phase, third heart sound, and during the atrial systole we hear the fourth heart sound. Okay, and I hope you know that this is the end systolic volume and this is the end diastolic volume, right? Okay, now tell me, the graph which is showing here is developed due to increased preload. Increased preload means here the preload is nothing but end diastolic volume, right? If I want to say the preload increases means this is the new volume taken by the ventricle, right? Now see what will happening to the graph. Is the graph shifting towards upside as it given in the graph? No, the graph is shifted towards the right side. So in increased preload conditions, the graph shift rightwards. Okay, and if you think of increased inotropy, that is increased contractility of the heart, what is going to happen? The systole will increase, and the graph shifted towards left side. Okay, and remaining one is increased afterload. Imagine what I said for the afterload. This is the pressure in the aorta, right, against which the pressure shoots up in the ventricle, then the semilunar valve opens and the rapid ejection phase begins, right? Suppose in case this aortic pressure has raised here due to some of the reasons, now what will happen? The afterload has increased, right? Now the graph will shift upwards and the stroke volume decreases and the end systolic volume also increases. So what will happen in increased afterload? The curve shift upwards, the pressure volume curve shift upwards, and stroke volume decreases and end systolic volume increases. As you could see here, it is moving from here. So this is the new point taken by the pressure volume loop for the increased afterload. The curve moves upward and stroke volume decreases and end systolic volume increases. Okay, this kind of, they can ask this image and they can ask number of valvular diseases and some kind of cardiomyopathies. Okay, so you have to think what is happening, whether the curve will shift towards the right side or left or upwards. Okay, moving on to the next question. The 75-year-old man with an atrial rate of 80 per minute develops third degree heart block. They have given the diagnosis third degree heart block, and a pacemaker site located in the AV node below the region of the block triggers ventricular muscle but at a rate of 40 beats per minute. Atrial rate 80 and ventricular at 40 beats per minute. What would be the observations? They just indirectly they are asking the ECG features of third degree heart block. Okay, so what could be the answer? 1 P wave for each QRS complex? No, there is no relationship between the ventricular pace and the atrial pace at which the heart beats, right? So this could not be the answer. An inverted T wave? No. Shortened PR interval? No, because first degree heart degree block there will be a PR prolongation will be there, and second degree heart block there are two types, Mobitz type 1 and Mobitz type 2. In Mobitz type 1 is Benke-Back phenomenon, in which the PR interval gets prolonged until and one QRS misses out. In Mobitz type 2, the PR interval remain constant, but randomly one of the QRS will be missed out. In third degree heart block, there won't be relation, that means atrial ventricular dissociation. No relationship between the atrial pace and the ventricular pace. QRS will come in a different manner and PVA will come in a different manner. Okay. So this also won't be the option. So you will find the different atrial and ventricular dissociation with normal or an QRS complex, normal QRS complex. Okay, normal or wide QRS complex can be get in third degree heart block. Okay, this is a very easy question. Okay, moving on to the next question. This is a calculation based questions. Okay, so 15-year-old teenager presents for a sports physical. Blood pressure is 100/70, temperature is 36.5 and the heart rate is 100 per minute. On cardiac auscultation, an early diastolic heart sound is heard over the cardiac apex while the patient is in left lateral decubitus position. And they did transthoracic echocardiogram and they found the ejection fraction of 60%, okay, without any other abnormalities. Which of the following is the end systolic volume? They are asking the end systolic volume if the patient's cardiac output is 6 liter per minute. Okay, so what could be the answer? Option A 50 ml, option B 60, option C 100, option D 40 ml. What could be the answers? Here we are going to use both the things, cardiac output, heart rate, ejection fractions. With the help of these three parameters, we are going to calculate the end systolic volumes. The end systolic volume is nothing but using this formula, we have a right end diastolic volume minus end systolic volume is equal to our stroke volume, right? Okay, so we need to find here, they are asking the end systolic volumes. Now we want to see whether we know this end diastolic volume, whether we know this systolic volume. If we know these two things, we can easily find the end systolic volume. So with the help of this, cardiac output is nothing but heart rate into stroke volume, right? Cardiac output by heart rate, which is nothing but applying this 6000 ml divided by heart rate is 100. So 60 ml is your stroke volume. Now we have to find the end diastolic volumes. How can we find end diastolic volumes? With the help of ejection fractions. Ejection fraction formula is stroke volume upon by end diastolic volume. From the end diastolic volume, how much amount of stroke volume is ejected out per the ventricles, right? So this is the ejection fraction. They have given this ejection fraction is 60%, and we know that stroke volume is 60, and we need to find end diastolic volumes, which is nothing but 100 ml. Applying this formula, end diastolic volume is nothing but 100 ml. Subtracting these two, we will getting the end systolic volume. So the answer for the question is 40 ml. 100 ml is your end diastolic volume minus stroke volume is nothing but your 60 ml, which is 40. Okay. Okay. Moving on to the next question. Which of the reflex responsible for tachycardia? Which of the reflex responsible for tachycardia? Option A, Bezold-Eris reflex, option B, Bainbridge reflex, option C, Cushing reflex, option D, J reflex. Which could be the answer? Guess, guys. Guess. Reflex responsible for tachycardia. Okay. First, we will see what are the reflexes and what are the receptors for the reflexes and where from it is produced. Okay. Option A, I am getting some answers. Option A, no. Guess. Okay, let me explain. Basal-Zaris reflex. Basal-Zaris reflex will be elicited whenever, first I will say the location of the receptors. This location of this receptor responsible for reflex is, they are present in left ventricle. Okay, this belongs to one of the mechanoreceptor, or it can act as chemoreceptors. Since I said this is a chemoreceptor or can act as a mechanoreceptors, these receptor can be activated by one of the chemicals, right? The chemicals which can activate this left ventricular receptor responsible for Basal-Zaris reflex is veratridine, serotonin, and another one chemical, capsaicin. These chemicals can act on this receptor found in the left ventricle and can stimulate this Basal-Zaris reflex. Once this reflex gets activated, the reflex you will get is decreased blood pressure, decreased heart rate, and coronary vasodilation and apnea. These are the reflexes you will get whenever these chemicals are act upon the receptors. Now tell me a situation where these chemicals are released and it can stimulate this Basal-Zaris reflex. In conditions like myocardial infarctions and reperfusion injuries, or whenever you are doing a procedures like as coronary angiography, these chemicals can able to stimulate this reflex. So here bradycardia is there. Okay. So what is Bainbridge reflex? This is the answer for this question. The receptor for this Bainbridge reflex is located in your right atrium. So whenever you inject a saline or a blood into the right atrium, the receptor for this Bainbridge reflex gets stimulated, and the center for the receptor is, the reflex is located in the medulla, and the response you will get is increased heart rate. And coming to the option number C, Cushing's reflex. This reflex gets activated whenever you have an increased intracranial tension, and this causes compression of all the vessels in the brain, and which will causes hypoxia, and this hypoxia can able to stimulate your vasomotor center directly. Whenever this vasomotor center gets stimulated, it will lead to increased sympathetic discharge, and which will lead to increased in blood pressure, right? So this increased blood pressure is sensed by our baroreceptors. These are high pressure baroreceptors. In Bainbridge reflex, there we have a low pressure receptors. Bainbridge we have a low pressure receptors, but in Cushing reflex the involvement of high pressure baroreceptor is involved, and once this gets stimulated, the information will be carried by the 9th and 10th nerve to the vasomotor centers and cardioinhibitory centers. Since the vasomotor center is already activated, the only possibility done by this increased baroreceptor discharge is activation of this cardioinhibitory center. When this gets activated, it will cause reflex bradycardia. So the response you will get whenever this Cushing reflex is increased blood pressure, hypertension. For that you will get an reflex bradycardia. Okay. And the option number D, J reflex. The location of this is juxtacapillary receptors in the alveolus. For example, this is the alveolus and this is the capillary. You will find this receptor in the alveolus, and these receptor won't get stimulated in a normal physiological conditions, rather it gets stimulated upon any diseases involving interstitium or any fluid collection in the interstitiums. For example, pulmonary edema or the pneumonia, where the J reflex gets activated, and the response you will get is apnea and decreased blood pressure, decreased heart rate. The response you will get is similar to that of Bezold-Zaris reflex. Okay. So you have to be very careful the response getting for any of these reflexes. Okay. Bainbridge reflex, it's a low pressure receptor activated by when we are injecting saline or blood into the right atrium. The center is medulla. The response you will get is tachycardia. Okay. Moving on to the next question. A 70-year-old female patient, estimated GFR is 100 ml per minute. His plasma glucose is 350 milligram per deciliter. What would be the renal excretory rate of glucose for this patient if the renal transport maximum, that is Tmax for the glucose, is 300 per minute? They are asking how much amount of glucose is losing in the urine. If we have a GFR 100 ml per minute and transport maximum of 300 milligram per minute. What could be the answer for this? Option A 50 milligram per minute, option B 30 milligram per minute, option C 150 milligram, and option D 100 milligram per minute. What could be the option? Guess guys. Okay, for calculating this question, we should first find how much amount of glucose is filtered across the glomerulus. For that, we should know what is the plasma glucose and we should know the GFR rate. Here we have the two values. The plasma glucose is 350 milligram per deciliter multiplied by the GFR 100 ml per minute. That will give you the filtered load of glucose across the glomerulus. Upon calculating this, you will get 350 milligram per minute. 100 ml and 1 deciliter will be equal. So 300 milligram per minute. They are telling that from this filtered load 350 milligram per minute, the transport maximum for the glucose that can be observed by the transporters is nothing, only 300 milligram per minute. Only 300 milligram per minute. This is the transport maximum for this glucose by the transporters available in the loops, okay, in the kidneys. So how much, if this is the transport maximum and this is the filtered load, how much will be the excreted in urine? Just subtract this. So the option A will be your answer. 50 milligram per minute will be the excretory rate of the glucose for this patient for the given clinical data. Understand? So we have to calculate filtered load and transport maximum. Transport maximum they have given 300 milligram per minute. Okay. Okay. Moving on to the next question. This is very easy question, simple question. Impaired function of aquaporin results in. Impaired function of aquaporin results in. Tell me, option A, nephrogenic diabetes insipidus, Liddle syndrome, von Hippel-Lindell syndrome, or Bartle syndrome. Very easy question. Yes, this aquaporin is the type of channel, water channel present in the kidneys in various segments, and the importance of this aquaporin channel with the given options is related to this nephrogenic diabetic insipidus, in which there is an impaired insertion of aquaporin channel in the late part of distal tubule and collecting ducts. Okay, since there is no functioning aquaporin there, the concentration ability of the urine will be lost and dilute urine will be lost in the urine, and what we call as nephrogenic diabetes insipidus. Okay. And in Liddle syndrome, what is the problem here? The problem for the Liddle syndrome is gain of mutation in E sodium channel, INAC channels. And what is the problem in a Bartter syndrome related to kidney? The problem is in the NKCC channel, in the thick ascending loop. What is the other syndrome related to this? Now is Gentleman syndrome. What is that? Where we have a problem, the Gentleman syndrome, we have a problem in the sodium chloride channel, in the collecting duct, the late part of distal tubules. Okay. So, INAC channel, it is a gain of mutation, is Liddle. Bartter syndrome, NKCC channel in thick ascending loop, and Gentleman syndrome is NACL in the distal tubules. Okay. And nephrogenic diabetes insipidus is the answer for this question, where we have a impaired aquaporin insertion in the collecting duct and the late part of distal tubules. Moving on to the next question. Basic electrical rhythm is produced by simple, very simple. Smooth muscle at cardiac end of stomach, antral G cell, interstitial cells of Cajal, and myendric plexus. Very simple, very simple. Yes, the answer is interstitial cells of Cajal, where we have the pacemaker cells located in the stomach, where the basic electrical rhythm is produced. Okay. The rate of the basic electrical rhythm is different in different segments. As we proceed further to the small intestine, large intestine, the rate decreases, and the rate is very maximum in this duodenum and minimum in the large intestines. Okay. Question number 22. All of the following are actions of secretin except. Definitely we can expect the questions of gastrointestinal hormones in this coming NEET. Okay. What are the options? Increase secretion of gastric acid, inhibits gastric emptying, increases the actions of CCK, increases the bicarbonate rich secretions. What is the option here? See, this secretin is a hormone is produced by S cells of the upper small intestine, especially duodenum and jejunum. It is produced by S cells. The main role of secretin is with the secretions, pancreatic secretions. Okay. If you consider the role of secretin with stomach, it has an inhibitory role. It has an inhibitory role to the gastric emptying, gastric motility, and gastric secretions. Whatever, if you take the relationship of secretin to the stomach is inhibitory. Now try to find the answer which is inhibitory to that stomach or not. Increases secretion of acid. Just now we have said that secretin, it has an inhibitory role in the stomach. So this is our options. Inhibits gastric emptying, correct. Increase the actions of CCK, correct. Increases the bicarbonate rich secretions, correct. Okay. Secretin does not have any role in the motility per se, either with gastric or either with intestine. Okay. But if you take the other hormone, cholecystokinin, which is produced by eye cells, which is having an permissive role on intestinal motility, and it is inhibitory to the gastric motility. Cholecystokinin, it is inhibitory to gastric motility and it is stimulatory to the intestinal motility. While secretin is basically does not have any role in motility, even if it is have, it is inhibitory to both stomach as well as intestine. Does not have any role in motility, but it has a very prominent role in the secretions. As we see, the secretin increases the bicarbonate rich secretions of the small intestines, and also it potentiates the actions of cholecystokinin. Okay. other two few points regarding the gastrointestinal hormones. G cells produces a hormone called as gastrin. Regarding with the gastrin, the points are, it is stimulatory to everywhere. It is stimulatory to stomach, stimulatory to intestine, everything, and it also stimulates the gastric mucosa. So trophic action also is there. So gastrin stimulatory, all stimulatory. And another one important hormone, glucose dependent insulinotropic peptide. Glucose dependent insulinotropic peptide. A few points. It is the only hormone which can be produced by all the three types of foods. Either it can be carbohydrate, fats and the proteins, it can be stimulated, and the only role of the glucose dependent insulinotropic peptide is to sense these food materials and to release insulin. This is the only role of this glucose dependent insulinotropic peptide. Okay, only the MCQs can be asked from these three: secretin, cholecystokinin and gastrin and GIP. Okay, mostly we can expect MCQ from this. Okay, question number 23, very simple, very simple. Which of the following image depicts paracrine signaling of cellular communications? Option A, option B, option C or option D? Paracrine signaling. Option B is the answer for this. And what is this one? This one is a endocrine signaling. That is, a cell or the gland secretes substance, and the substances, the hormones travel in the blood vessels and it act on the distant site from the site of production. So it has to travel in the blood vessels and it act on the distant sites. But here a paracrine, the cell secretes some of the molecules and it act on the nearby molecules. It travel to very few distance and it act on the nearby molecules. This is paracrine. This is paracrine. What is this? The cell secretes something but it act on itself. Very simple. The target cell sites on the same cells. Autocrine. And what is this? The cell is having a contact with the nearby cells. Even though there is some gap, but this ligand and the receptor found in the receptor cell are in a direct communication. But in paracrine, the substance has to travel to some distance. It does not have any contact. But here, the signaling molecule and the receiving molecule have a contact with each other. Contact signaling. Okay, which is called as juxtacrine signaling. Okay, very simple questions. Coming to the next question. A 30-year-old man was examined for sensory neurological examinations. Which of the following cutaneous receptor is correctly paired with the type of stimulus to which it's most respond? The best stimulus for the receptors they are asking. Option A, Pacinian corpuscle and rapid vibration, Meissner corpuscles and skin stretch, Merkel cells and slow vibration, or option D, roughness corpuscles and sustained pressure. What could be the answer? The option A, Pacinian corpuscle and rapid vibration is the correctly matched for the receptor and the best stimulus at which response. Okay. We will see the receptors, the Meissner corpuscles and Pacinian corpuscles are the rapidly adapting receptors. This is the rapidly adapting receptors, and Merkel cells and roughness endings are slowly adapting receptors. And the best to stimulate the Pacinian corpuscle is vibration. The best stimulus to stimulate this Pacinian corpuscle is vibrations. Okay, and in order to stimulate Meissner corpuscles, the best stimulus is movement laterally, or this lateral motion. The best stimulus for Merkel cells is points, edges and corners. And the best stimulus to stimulate the roughnecks endings is stretch on the skin. So, okay, these are the best stimulants for these receptors. But an additional point regarding the three receptors, Meissner's corpuscle, Merkel cells and Peyssinian corpuscles, regarding with the vibration stimulus. I have said the Peyssinian corpuscle is the best stimulus to stimulate the Peyssinian corpuscles is vibration, and especially high frequency vibration of about 20 Hz per second, high frequency vibrations. But vibration can also sensed by the other two receptors, Meissner and Merkel's, but that is not the best stimulus to activate those receptors. It can also stimulate. Meissner's can stimulate a high frequency of around about 50 Hz and Merkel's of about very low frequency around about 5 Hz. Very high frequency Peyssinian corpuscle, and it is the best stimulus to stimulate that receptor. The best stimulus for stimulating Meissner's is lateral movement. The best stimulus to stimulate Merkel's is points, edges or the corners, but frequency range of 50 can also stimulate Meissner. 50 Hz of about 5 can also stimulate Merkel's disc. This you have to be very clear about this. And the Merkel cells having a very less receptive field. Since it is having a receptive field, it is involved in 2-point discrimination. The receptor involved in 2-point discrimination is Merkel's cells. And also another one important MCQ regarding this Merkel cells, the person who are all blind, the person who can able to read that braille reading, right? The receptor involved for the reading this braille by the blind person is Merkel's disc, because in Merkel's disc we have the rounded edges everywhere, and the person can able to locate over that edges and can sense that, and after that the person is also moving their finger on the edges and they are trying to find the configuration or the symbols or the signs written over there, right? So there also involvement of Meissner's corpuscles, because there the movement of the finger is also involved. We know that if movement is involved, Meissner's also gets activated, because Meissner's for the best stimulus is movement, lateral motion. But in case if the two options are there, first Merkel's, Meissner's, if the two options are there, you have to choose Merkel's. Merkel's over Meissner's. This is the best answer for this blind persons. Okay, first, why Merkel's is very important? First, the person has to feel for the round edges and he has to sense whether the edges are there, how many edges are there, they have to feel that. Then only the person will roll the laterally and try to find the symbols or the letters over there. Okay, so you have to be very careful. If it is a multiple choice, you have to choose Merkel's and Meissner's. If it is a single and best choice is Merkel's. Clear? Moving on to the next and the last MCQ for the today's session. What is the electrophysiological principle behind the transcutaneous electric nerve stimulation for the treatment of pain? They are asking what is the principle behind this TENS, transcutaneous electric nerve stimulation. What is the answer? Option A, endogenous opioids. Option B, supraspinal control of pain. Option C, gate control theory of pain. D, nerve ablation. What could be the answer? The answer for this MCQ is gate control theory of pain. Whenever they are doing this procedure, they are simultaneously activating the large diameter fibers, A beta fibers. Normally what happen, the pain fibers is carried by the A delta as well as C fibers, right? Whenever they reach the dorsal horn of the spinal cord, from there some projection neurons will be there and it is transmitted to the thalamus, right? But while going to the projection neurons, it also sends some connections to the inhibitory interneuron present there. But while the pain sensation is going on here, it inhibits the inhibitory interneuron, so that the pain travels over the projection neuron since the gate is open here. Now the gate is open. But if you apply pressure, bandage, ointments like that, the fibers carried by the A beta fibers, while the A beta fibers will go to the dorsal horn of the spinal cord where the pain fibers also coming, it sends impulses to the inhibitory interneuron. Now this A beta fibers, it activate the inhibitory interneuron, so that here it will try to inhibit this sensation carried by the pain fibers. So now the gate is closed. This is how the activation, simultaneous activation of the large diameter fibers controls the gate for the traveling of pain. The center for this gate control theory is the dorsal horn of the spinal cord. This is at the level of spinal control of pain sensation. Dorsal horn of spinal cord. Okay. The principle acupuncture or the transcutaneous electric nerve stimulation, when you apply pressure, ailments, okay, all the principles is because of this gate control theory of pain. Clear? Students, if we with this we have completed this session of 25 MCQs in the 2 schedules, and if you have any doubts you can post, and if you can contact us anytime. Okay, stay tuned with Medicoz community for the updates on the contents. Thank you guys. Good night.